The comparison of the demineralized bone matrix putty. There is a little bit of BMP and DMP, for instance. BMP alone doesn't provide the osteoconductive scaffold. Autogenous bone marrow aspirate. Well, okay, it doesn't actually have the concentration of stem cells. Sometimes it's necessary to get a non-human to go on to heal, and you have to have a second site. So ceramics are basically tricalcium and calcium phosphates, for instance, and again, it simply provides a scaffold, but it doesn't really create an osteogenic response or conductive. An allograft bone itself, again, it's that bone, it's a good scaffold. It loses the generator cells, and so you've got conduction and you've got induction if you don't have osteogenesis. The advantages of osteocell over other autografts is, again, you don't have the complications associated with having to harvest bone from somewhere else. It decreases the operating room time. Yeah, there is a morbidity that's associated. The longer you're on the table, the greater the chances that something bad is going to happen to you. We've done plenty of studies as far as post-operative infections. So you really want to minimize that. The product offered me at least 50,000 cells per cc with about a 70% viability, at least at the time. Your numbers are greater with what you're producing now. Okay, and this is simply as far as identifying the cells. And these markers here are for the stem cells. These markers are what you don't want. This is the CD45, and this is all kind of washed out, if you will. These are the hematopoietic cells. They have the ability to stimulate a graft versus host reaction, and you don't want that before you do somebody else's product. Okay, characteristic markers. Again, all material that we've pretty much covered. If you aspirate within the bone, pretty much one stem cell per 500,000 nucleate cells. Not a real high concentration that exists in the bone. And per cc, that turns out to be about 1,000 to 1,500 stem cells in bone marrow aspirate. And that's important because if you're going to have a non-union, you want to put a whole lot more bone cells, stem cells here if you can, because that non-union will heal. Case studies of various. Okay, so I guess these are my cases, and we've got triple arthrodesis. This is again, as I mentioned, it's an extensive procedure. 10 weeks of non-weight bearing, typically followed by several weeks of protective groups. This is individuals, a 44-year-old with severe degenerative arthritis, and if you look at the orientation on the X-ray of the talus, it's supposed to be pointing out this way, it's pointing down into the floor. This thing is collapsed, there's spurring at this particular level, there's arthritic changes, and there's pain. Also, he was 44 and he didn't know he had CP. But he did have his spastic equinocyte and the length of his Achilles tendon as well. This is him at 1 week post-op. You can see that there's actually some fairly hard, dense subchondral bone at this level. It's not the best healing to occur, but of course I cheated, I used stem cells. At 6 weeks post-op triple, what you're seeing here is the beginning of that consolidation. There's real bone activity that's occurring here. And again, if you're sitting in the back, perhaps you can't see this, and I apologize. But he was also weight-bearing somewhere around 3 to 4 weeks after surgery. That's an improvement. Because if you can get them to weight bear earlier, and again, this type of technology helps, then you avoid all the risks associated with being in a cast for a long period of time. Your bone wastes away. There's something called disuse osteopenia. You have swelling, fibrosis. You have increased stiffness, pain associated with it, and you're trying to get back up on your foot. The blood begins to pool. You get deep vein thrombosis, so you can have embolism, pulmonary embolism, and death as a complication from a prolonged period of immobilization. The beauty of being able to get people up on it is that's something called dynamization. We've learned that from external physician in the past, is that if you can get them to bear weight and control the motion, so there's no real motion at that level, then you can stimulate those osteoblasts to increase their activity as well. This is at 10 weeks post-op, and you can see that, again, there's some significant changes back here. Get a little fused. This poor guy, I think he's from Kenya. TEV stands for Talipes equinovarus. He had a club foot when he was a kid. They casted him and never bothered to really fix it properly. He walked on the outside of his foot, and he worked for UPS. Bad choice, yes. But in any case, he needed a triple arthrodesis. He had extensive arthritic changes. And here he is 1 week afterwards. And again, I cheat. I'll use anything, everything I can to get that to heal. He's just lost. But I brought along some videos, and hopefully if we get this thing back up, you'll be able to see this guy walking. Hopefully the audio portion will also. Well, this is the question and answer period, actually.
Yeah.
There we go. Okay, no questions. Thank you. 1 week, and you can see I use cervical plates. Neurosurgeons typically use them. I use them in foot surgery because they're blocking. and they're load bearing, and that helps me a great deal. And that's working on a new product that actually locks the plates together that facilitates the earlier shift. Here's Kenny. He's 13 days after his triple arthrodesis.
He's on his side. We couldn't rotate him. We tried.
Yeah.
Oh.
After the surgery, he was able to walk on walls.
Amazing.
I know. Wow.
I can do this for you.